We'll move forward to the next talk, open interventions, grafts, and techniques. I haven't developed any new disclosures in the last 15 minutes. So first off, why do we care? It's still critical to know open for limb ischemia. So this is a study that my fellow had done. There's an analysis of the NISQIP database from 2006 to 2012 is about 23,000 patients, and it showed that an increasing proportion of these cases, lower extremity bypasses, are being performed by an attending alone, from 31% to 46%. And this is significant because when you propensity match the cohorts, those that were operated by attendings alone versus attendings plus a resident, those that had a resident had an increased operative time as well as increased intraoperative transfusion in EBL. So there is a marginal difference between some of those, some things that the attendings are doing that the residents still have to learn. So with that intro, we'll start talking about open surgery. And open surgery, if you break it down, it consists of 4 main things. It consists of conduits, consists of exposures, tunneling, and then just some common operations. I'll just show you how they work. So multiple types of conduits exist. The main ones are autogenous, and those include greater saphenous vein, femoral vein, alternative venous veins such as arm vein, lesser saphenous veins, and then there's other veins that are often sometimes used, like the silics. So what is the greater saphenous vein? It is the gold standard and remains the gold standard today ever since Kuhnlin started using it in the late 1940s, early 1950s. But the first person to ever do a femoral tibial bypass was a gentleman by the name of Dr. Dale. What are the differences between veins and arteries? You guys should be aware of at least some of the basic tenets that are different between the two so you understand what you're doing. So veins and arteries, their endothelium is very different. The endothelium between veins, they have a loose cuboidal endothelium, whereas the arteries, they have lots of tight junctions and tight desmos. So what that means is that the veins are a little bit leaky relative to the artery, and a lot of cytokines, et cetera, can translocate from the adventitia into the intima and vice versa relative to an artery. Now, the other thing is that the veins lack elastin relative to the arteries. So what that means is that once the vein is arterialized, it actually becomes relatively fixed and tense, whereas the artery can actually expand and contract with diastole and systole. The other thing is the adventitia is the main source for myofibroblasts, so you want to handle the vein very gently. It remains the gold standard, but unfortunately is absent in up to 40% of patients. So when you are harvesting the vein, this is a picture of a femoral vein harvest, one of my favorite things to do, actually. But because of all the differences between the veins and the arteries, one of the goals when you harvest this is to minimize trauma to the endothelium. So handle it very gently. What you see in the diagram there is how we handle the vein, even for the femoral vein, which is a very robust and thicker vein than the greater saphenous vein. Use vessel loops to manipulate it back and forth as opposed to grabbing it with your pickups all the way down. Because that's going to minimize the trauma to the repetitive crush injury that you're going to induce to the intima. You can have any configuration you wish, non-reversed versus in situ and reversed. It doesn't matter with respect to patency. Vein solution, there's no consensus, though most of them have some contribution of both vasodilatory agents like papaverine as well as heparin in them. You can use crystalloid, you can use some whole blood in them if you want to. But there is no consensus on what constituents you have to have in your vein solution. So long as it remains cold, it helps to dilate, and it doesn't clot. Okay. The best patency for greater saphenous vein is when you have a vein diameter greater than 3.5 millimeters. This is shown in the sub-analysis of the PREVENT-3 trial data. 7% occlusion rate versus over 14% when they're less than 3 millimeters. Other types of grafts, the most common types of prosthetic grafts that are out there are Dacron and expanded polytetrafluoroethylene, so we'll go over those now. So Dacron is a very common fabric that's used. It's polyethylene terephthalate. It's chosen for its strength as well as most of its negative charge throughout. There's 2 major configurations. You can have a knit or you can have a weave. So a weave is a single strand that's sewn in such a way that everything interconnects, whereas a knit is multiple strands that are set at right angles to one another. So the the woven requires a loom in order to put together. Some of the differences between knitted and woven that are most significant for you, for the woven, when you cut across it, you're going to actually have little pieces that break off. It's more friable. The other thing about the woven is it's less distensible. and it doesn't degrade as much and dilate as much over time. But otherwise, there's been no significant differences found between the two configurations. It was initially devised and utilized by Dr. DeBakey in the 1950s. The crimping is also done to allow for more longitudinal stretching of the material, whether it's woven or knitted. Dacron is extremely durable, but dilation is pretty common, especially within the first month and then up to 5 years, after which the dilation stabilizes out. The amount of dilation that you experience, there's no statistical relationship with complications. In the literature, if you look over time, one of the most thorough reviews of the literature on this topic was published in 2009, and they found 68 late degenerative disruptions that were only due to degeneration of the dacron itself. They excluded infections. So if you consider the vast number of dacron implants that have been placed, 68 is pretty small. So dacron is very durable. Moving on, ePTFE. The reason why it's so popular is inert and has very minimal porosity. This was initially devised for use in the vascular tree by Ben Eisman in Colorado. He met one of the guys from Gore on a ski trip up in Vail, and they started talking, and they started developing grafts together. Some of the attractive things about it: highly negative charge. If you can see the chemical formula there, you see all the fluorine molecules. It just exhibits a lot of negativity, which helps prevent a lot of clots from forming on it. It's more negatively charged than dacron. It's not cytotoxic. It's very inert. That's why they use it in Teflon, the magic no-stick fry pans. They have what's called a node and fibril design, which is a phrase that I think you want to remember if you want to remember about expanded PTFE, which allows for space in between. They can actually control how much space you have in between the actual chemicals and a little air pockets inside that allows for cells to ultimately intercalate and incorporate the graft. PTFE is also very durable. This is just one of many prospective randomized controlled trials that have been studied on this topic in both the aortoiliac position as well as in the periphery. But this is just one that I chose because I thought it was especially well done. Prospective randomized controlled trial of about 315 patients in 3 arms. And what they found was that there was no statistically significant difference between primary or secondary patency between ePTFE and knitted dacron, whether or not it's soaked in gelatin or collagen. So all 3 are very durable methods of reconstruction. One conduit that's not ideal are a lot of the biologic conduits, so the cadaveric preparations. And this is a paper that was done by one of my colleagues down in Florida, Chung, who's no longer there, unfortunately. But she published a great paper while she was there that looked at the results for cadaveric greater saphenous vein grafts and found that they had markedly reduced patency relative to prosthetic bypasses and, of course, autogenous greater saphenous veins. So 1-year primary patency is 27% with a 3-year primary patency of 17%. So it's, I would consider this as a last resort in infection, and you have no other conduits for patients. So after you've decided on the conduit, you have to look at the exposure of both your inflow as well as your outflow vessels. So with respect to inflow, the most common site is the common femoral artery. However, it doesn't appear to actually influence your patency. Belota et al. Back in 2004 looked at multiple bypasses where you had variable sites of origin for your bypass grafts. And while the common femoral artery is the most common, there was no statistically significant difference with respect to primary or secondary patency depending on the site of origin of the grafts. There have been some smaller studies recently published that suggest that optimization with stents may help if you optimize the inflow, but that's still up for further study. So moving on to some of the exposures, the common femoral artery exposure is probably essential to understand. You're going to do this more than any other open exposure in the groin or in the leg. So I typically use a longitudinal incision. This is especially when you have disease or plaque within the common femoral artery. I want to make sure that I have enough length to get all of it out. I like the lymphatics that I encounter along the way. I think this helps reduce late lymphocele, though there's no actual data support that. That's my personal practice. After I get through the initial subcutaneous lasers, I identify the inguinal ligament and I mobilize along the length of the inguinal ligament down, and then until I find and encounter the common femoral artery. It's the most constant place. So when you're operating on redo groins, very obese patients, this is the easiest way to find your common femoral artery. And once you find it, you can just track it straight down and mobilize the entire common femoral artery, SFA, and profunda femoral artery. Also be aware that I like this particular picture because it shows that venous branch that goes underneath the superficial femoral artery, the lateral circumflex vein, femoral vein. So whenever you're trying to encircle the SFA at that point, just be aware that there's a nice juicy purple structure that bleeds a lot. Moving on down the leg, the above knee popliteal artery exposure, you want to make a longitudinal incision proximal to the medial condyle in between the sartorius muscle and your vastus and rectus femoris muscles. In most patients, you can sort of feel it. There's just a little groove right there. And after you incise through the subcutaneous tissues and the fascial layers, you'll reflect the sartorius muscle posteriorly and reflect the adductor magnus superiorly. And as you continue to dissect down, you'll encounter both your popliteal artery and vein in that position. Rather constant position. This is just a cross-sectional image so you can get a better idea of exactly where that lies. Below the knee exposure, 1 finger breadth below the tibia and several finger breadths below the tibial tuberosity, incised down through the subcutaneous tissues, reflect the medial head of the gastrocnemius posteriorly, and you'll enter a space, and that has just some loose areolar tissue and fat. And as you bluntly dissect down, you'll encounter usually first your popliteal vein, and with further careful dissection, you can identify your popliteal artery. In some patients, the fused tendons of the gracilis, sartorius, and semitendinosus form a pes serine, a structure that's lying a little bit low and can interfere with the exposure of your popliteal artery. And so in some of these patients, you may wish to transect this in order to aid your exposure. In the textbooks, they describe putting it back together with a vicryl at the end. I've never done this, and I think for most of our patients, they're not going to be Olympic high jumpers. They don't necessarily need it, so it's not required. Anterior tibial artery exposure, you want to incise over the anterior tibialis muscle in the anterior compartment in an area where it's shown to be by your preoperative imaging to be patent. And incise, after you incise the fascia, try to identify that gap in between your tibialis anterior and your extensor digitorum longus muscles. As you carry that all the way down to the fascia, you're going to run into your anterior tibial vessels right there. Exposure of the tibial perineal trunk, I think this is an important one because this has a few nuances relative to the below the knee popliteal, or that's a little bit different than the tibial exposures as well. So the tibioperineal trunk, it's very similar to your below the knee incision, except it's a little bit lower. You also want to mobilize the soleus off of your deep compartment, and once you do that, you'll find the deep posterior compartment. And you want to transect that soleus and then start to enter that and take that extensor fascia down. And the reason why I highlighted this one in particular is because when you see the tibioperineal trunk, you're going to identify the anterior tibial artery and the tibioperineal trunk and the below the knee popliteal artery. There's a vein that crosses over the anterior tibial artery before you're able to encircle it with a vessel loop, and that's going to be your anterior tibial vein. So make sure that you get adequate control of that and ligate it and divide it before you attempt to encircle your anterior tibial artery. It's often a deep and tight space. Posterior tibial artery exposure, what I usually do, depending on where it is, especially if it's further distal along the leg, I'll just use a Doppler or a duplex and identify where it is, mark it, make an incision right along it, and then reflect the tendons of the flexor hallucis longus and digitorum longus as needed to identify this. There's a lot of small veins in this area, so tread lightly here and take your time. Perineal artery exposure. The one that I've been liking lately is the lateral approach to the perineal artery, which requires transection of the fibula, or the middle third of it. And just simply make an incision along the fibula in the region that you like. Make it longer than you think you're going to need. And then dissect very carefully around the fibula. When you're getting around the fibula, this is where you want to be particularly careful because the perineal vessels are right underneath it. So once you get underneath it, I use one of those pigtail rongers and go up and down and stay right on the fibula. And once I do it, use the bone shears and again, very carefully transect your fibula and make sure that you don't cut the perineal vessels that are right behind it. You can safely take the fibula up to the lateral malleolus, according to one of the ankle surgeons over at Baylor, who I asked about this. And approximately, you can take it out if you want to, though you will have to be careful. You're going to run into some nerves, the common perineal nerve, as well as its two branches, the deep and superficial perineal nerve. And when you get up there and you take that segment out, you're actually getting up to a lateral approach to the below the knee popliteal artery, which has been described, but not very commonly performed. So medial exposure of the perineal artery, I do this when you get very further distal in the leg, because usually the leg is a lot smaller in that case. It's a lot more difficult in the middle third of the calf. You have to find the fibula, work your way all the way down. When you find the posterior tibial artery, go further until you hit the fibula, and then you'll run into the perineal structures. Dorsalis pedis exposure, it's 1 centimeter lateral to the extensor hallucis longus muscle, so when they're in the pre-op area, have them pull their toe up towards their head, and you'll get their extensor hallucis longus to show up, and make your incision just lateral to that, and you'll identify your dorsalis pedis artery in that section. Medial plantar exposure, again, I simply just use a Doppler and trace it down, or a duplex, and then trace it out and then make my incision over it. For both of these, the dorsalis pedis and the medial plantar, I tell you that the vein is required for either of these bypasses. It just simply doesn't work with prosthetics. Other exposures that are good for you to know, the lateral exposure to the profundifemoral artery. This is very useful, especially when you have hostile groins or infection. What you want to do is draw a line from the anterior superior iliac spine to the medial condyle of the femur. This will mark out your sartorius muscle for you in size in the region of the profunda, and reflect the muscle medially. You want to reflect medially because all the segmental blood supply of the sartorius is on the medial aspect, and then transect any crossing veins, and you'll run into the profundifemoral artery. It's not very difficult. So next, after you do your exposures, you want to tunnel, and there are several ways to tunnel. You can tunnel either superficial to the muscle or anatomically subsartorially. Tunneling superficially has some advantages. You may avoid infected fields. It's a less direct path, though, so it requires a little bit more graft, but you do avoid the risk of perhaps tunneling through muscle. And in theory, it's easier to revise. So if you have some spliced vein grafts, for instance, that are more prone to develop stenoses, it'll help you if you want to do open surgical revisions of these. But tunneling anatomically is ideal. It's deeper, prevents it from getting infected, avoids kinking, avoids graft exposure, and it's a more direct path, so you have shorter lengths that are required, less vein. You do risk tunneling through muscle, and it can be difficult when you do surgical revisions. So after you do that, you have several very common operations. You have your aortobifemoral bypass, which you can do either in an end-to-side configuration or an end-to-end. The end-to-side will help preserve your pelvic perfusion, requires a little bit less dissection. Some early complications with this: renal dysfunction, colonic ischemia, impotence, and lower extremity ischemia. Late complications include limb occlusions and graft infections. So I'm going to try and go quickly since we're running short on time. Other options: aortic endarterectomies. So in this particular instance, you can do this either from a transperitoneal approach or a retroperitoneal approach. But in either way, you want to obtain usually supraceliac aortic control first, and then perform the endarterectomy and remove all the disease that includes that which is found in the visceral ostia. And then you can do either a primary closure or a patch closure with 4-proline, and primary patency rates exceed 90%. Just keep going. This shows the patency of either the aortobifems and the aortoiliac endarterectomies for either claudication or critical limb ischemia. The main distinguishing thing in patency for either of these reconstructions is the severity of the ischemia at presentation. It's not the actual reconstruction itself. Other options: iliofemoral bypass. So again, you just expose the two arteries and then you name your bypass essentially, right? So you can do an iliofemoral bypass. Usually do it end to side, and the graft is deep to the inguinal ligament and the ureter. Patency is excellent, 72 to 85%. Femoral bypass, not a great operation, but you're going to have to do this in order to salvage some people. It's advantageous in poor risk patients, and because these can be done under epidural or a spinal. The technique: you expose either common femoral artery, you perform a subcutaneous tunnel over the pubis. The patency is poor, however, about 50 to 80% of the time. Just to tell you, some patients you want to be aware of when they've had a prior midline incision. I've seen one of these tunneled through bowel that was going through a hernia from a prior midline incision. Not fun. Other options, axillofemoral bypass. Again, for high-risk patients, you go from the axilla down to the common femoral, and then you want to do a femoral-femoral crossover bypass graft. The bifemoral grafts tend to have superior patency versus the axillounifemoral bypass grafts, just due to the improved outflow that you have. Their primary patency is about 50 to 85%. This is your bread and butter operation. You're going to do tons of these common femoral endarterectomies. So after you isolate the entire proximal common femoral artery where you have a pulse and the SFA and profunda distally, you want to incise anteriorly, perform an endarterectomy in the deep medial plane, remove the plaque in toto, and then sew it shut with a patch. Okay. Other things, the femoral popliteal artery bypasses. I'm not going to go into too much detail about these, but in terms of your primary efficacy, this is defined by Conti et al. They defined your goals for your quality. But most of your standard benchmarks, you're going to want to have primary patency rates of about 80% if you're using greater saphenous vein and PTFE. Above the knee, you're having about 70% at 5 years, and primary patency of about 20 to 40% below the knee. Pedal bypasses, first championed by Dr. Pompaselli in Boston. His series showed that you can have excellent patency and limb salvage, 1 year patency of about 55% and limb salvage of about 80% as well. For tibial bypasses, patency of about 50 to 70% at 5 years and limb salvage rates of about 75 to 90% at 5 years. Okay. And for malleolar bypasses, I'll finish with this one. Early failure rate's pretty high, 11 to 29%, and vein is required for those. So this is a really fast fly-through through a lot of the open exposures and tunneling techniques. I think just to emphasize and conclude, critical to know how to do infrainguinal bypasses even in this day of endovascular for the reasons I mentioned at the beginning. It's conduit, exposure, tunneling, and then the anastomosis. The anastomosis, the actual technique of anastomosis doesn't necessarily matter. There's been no differences with those. But if you know the other three, conduit, exposure, and tunneling, you can do pretty much any operation. So with that, I'll close. Thank you very much.